Hello everyone. In this video, we are going to see about Lichen Planus and its management. So what is Lichen Planus? So lichen means a plant or mosses that grows on trees or rocks, and planus means flat. So based on its appearance, British physician Erasmus Wilson coined the term Lichen Planus in the year 1869. So it is an immunologically based disorder which affects both mucous membrane and skin. So it is also called as mucocutaneous disorder. Coming to the epidemiology of oral lichen planus, it affects women most commonly, that is middle-aged adults of 4th to 6th decade of life, and it can either involve the oral manifestations alone, that is 25% percentage has been reported, or it could be associated with cutaneous LP, that is of about 75 to 77 percentage. Coming to the etiology of oral lichen planus, so as we already discussed, it's an autoimmune disorder. So it has a genetic predisposition of certain genes, and when it is involved with dental materials or drugs, it could be called as lichenoid reaction rather than lichen planus. And some infectious agents like gram-negative bacteria, HPV virus, Epstein-Barr virus, and hepatitis C virus have also been implicated in the etiology of oral lichen planus, and stress and along with other syndromes also been associated with oral lichen planus. So this is one of the common syndrome called Greenspan syndrome. This is mainly associated with diabetes mellitus, hypertension and oral lichen planus. But later it was told that it is because of the drugs that is used for diabetes mellitus and hypertension causes lichenoid reaction rather than lichen planus itself. Coming to the pathogenesis of oral lichen planus. So all the etiological factors can result in antigen expression or unmasking the antigen or actinizing the antigen that is present in the basal cell keratinocytes. So these antigens are identified by antigen presenting cells, and these antigen presenting cells presents the antigens to T lymphocytes. So what it does is it causes migration of T lymphocytes to a oral epithelium and activation of T lymphocytes and release of certain cytokines, which results in more recruitment of T lymphocytes and killing of keratinocytes and basal cell degeneration. So this is what the overview of pathogenesis of oral lichen planus. Coming to the clinical types of oral lichen planus, there are about 6 types that has been presented by Andres, which is reticular, papillar, plaque-like, bullous, atrophic and erosive. So why is there a different clinical manifestation? So whenever there is a degeneration of the basement membrane and the basal cell keratinocyte, there will be inflammation at the subepithelial layer and at the basement membrane zone. So based on the magnitude of subepithelial inflammation, it could be classified into different types as we have mentioned before slides. So when there is a mild inflammation, it stimulates the keratin layer to be formed and results in hyperkeratosis that results in reticular, papillar and plaque type of LP. So when there is intense inflammation where there could be a deterioration of epithelium instead of keratosis formation, it could be erosive, atrophic and ulcerative type. But most commonly in oral lichen planus, in atrophic erosive type, there will be central erythematous with a peripheral keratotic layer. So which we'll be discussing in the upcoming slides. This is the most common type of oral lichen planus, that is reticular type, which includes or characterized by fine whitish lines or striae, which can be present as a annular or circular pattern. So this is nothing but the Wickham striae. So Wickham striae is one of the characteristic or pathognomic feature to diagnose oral lichen planus, but it can also present in lichenoid contact reactions or drug reactions where history eliciting is important to rule out these. So it can be present as bilaterally in the buccal mucosa or other areas of the oral mucosa, and it can also involve the vermilion borders of the lips. Next is papillar type of oral lichen planus. So in this we could see fine small white dots that is intermingled with a reticular form of oral lichen planus, or it could be present as isolated small white dots. Next type is plaque type of oral lichen planus. So it is characterized by homogeneous, well demarcated raised patch which occurs in conjunction with Wickham striae. So this should be differentiated from oral leukoplakia, where we could see the homogeneous, well demarcated white plaque but without Wickham striae. So these are the differentiating feature between oral leukoplakia and plaque type of oral lichen planus. So next is bullous type of oral lichen planus, where we could see the bulla surrounded by a reticular type of Wickham striae or peripherally radiating Wickham striae. It could be circular also, as we can see in this picture. Next is erythematous or atrophic type of oral lichen planus, where we could see the atrophic or homogeneous red area along with the peripheral radiating striae. So when it is involving the gingiva alone, whether it is the marginal gingiva or it can involve the attached gingiva also, it will be appearing as a discomnative gingivitis, where on palpation the gingiva actually discomnates. So on this, when you see this feature, it should be differentiated from other autoimmune diseases like pemphigus or pemphigoid, where we could see this discomnative gingivitis feature. So discomnative gingivitis is not a characteristic feature of lichen planus. So we have to go for a biopsy to differentiate from other conditions. Next is erosive or ulcerative type of oral lichen planus. It is the most disabling form, where we could see a loss of epithelium and exposure of connective tissue with a fibrin coated ulcer along with peripherally radiating striae at the along the periphery of the lesion. Coming to the diagnosis. So as we said, first history eliciting is important, because we have to know whether it is associated with any drug or any dental materials like amalgam. So based on that, we could able to differentiate between lichenoid contact reaction or lichenoid drug reaction from oral lichen planus. So if there is no etiology association, then we can go for a oral lichen planus. Next, coming the clinical feature, where the peripheral Wickham striae along with the skin lesions can further strengthen the diagnosis. But Wickham striae is one of the characteristic feature in all type of lichen planus. Then biopsy. So as I said, discomnative gingivitis is not a characteristic feature of lichen planus. It could be present in other conditions like pemphigus and pemphigoid also. So in order to differentiate that, we have to go for a biopsy to differentiate between other conditions from oral lichen planus. Then lupus erythematosus, like discoid lupus erythematosus that is affecting the mucous membrane, can also present with the Wickham striae features. So in order to rule out that, we have to go for a laboratory testings that includes ANA. Coming to the histopathological feature of oral lichen planus. So as we said in the pathogenesis itself, it is a T cell mediated degeneration of basement membrane and the keratinocytes. So we could see the basement membrane degeneration, and along with sawtooth retipex, along with there will be intense subepithelial inflammatory infiltrate, which is predominantly of T lymphocytes. So based on the degree of inflammation, there will be hyperkeratosis at the corneal layer and prominent granular layer. So this is the histopathological feature of oral lichen planus. Coming to the management part, so first of all, patient education is important in the treatment of oral lichen planus, because there is no cure for oral lichen planus. So main treatment is to limit the progression and reduce the exacerbation of the disease and to relieve the symptoms of the patient. So patient must understand that this illness is chronic and it can wax and wane over time. So palliative treatment is the goal here. So we have to encourage the patient for routine follow-up, and excellent oral hygiene is required in order to reduce the exacerbation of the disease. And if there is any trauma association like sharp cusp or sharp teeth, any gingival restorations that can traumatize the tissue, all these should be identified and eliminated properly. So after patient education, initiation of therapy is required for symptomatic cases of oral lichen planus. So if the lesion is asymptomatic, regular follow-up of every 6 months is required in order to rule out any malignant transformation. Because oral lichen planus is considered as a potentially malignant disorder according to the classification of oral potentially malignant disorders 2018 vernacular Surya. So, in order to look for any lesional change, we have to keep a regular follow-up of asymptomatic lesions. So, if it is mildly symptomatic, we can be treated with topical steroids for acute exacerbation. If it is generalized, when it is associated with a cutaneous lesion also, then we can go for systemic steroids or systemic immunosuppressants. This is the treatment guideline that was given in Burkitt. So when we are dealing with symptomatic lesion that includes erythematous or erosive or ulcerative type of oral lichen planus, first line of management includes topical steroids, which includes medium or high potency steroids, which can be used as an ointment and gel form for localized lesion, mouthwash or a spray form for widespread lesions. It can also be given as intra or perilesional injections if needed. So that includes betamethasone ointment, clobetasol ointment, fluocinolone ointment, or triamcinolone acetonide or methylprednisolone as intravenous injections, then dexamethasone as a mouthwash, and fluticasone as a spray. So when we are dealing with all these steroids, it can result in concomitant oral candidiasis. So in order to prevent that, topical antifungals are prescribed along with the steroid creams. So when the patient is contraindicated for steroids, then alternative to the first line of management includes topical calcineurin inhibitors. So which is an immunosuppressive agent that includes tacrolimus ointment or cyclosporin mouthwashes. So when the first line of management fails, if the patient is unresponsive, then we can go for second line of management that includes systemic steroids of methylprednisolone or prednisone or dexamethasone should be given in a tapering form of regimen. So tapered regimen is necessary in order to prevent the side effects or adverse effects of the steroids. Then if second line of management also fails, then going to the third line of management. That includes systemic immunosuppressants of cyclosporin or azathioprine. Other modality of treatment of oral lichen planus includes low-level laser therapy or photobiomodulation therapy that includes 980 nanometer diode laser or 904 nanometer pulsed infrared rays, which helps to destroy the superficial epithelium that is containing the target keratinocytes. So this can also be tried, and recent studies have shown that it has a good improvement, or it is considered as an alternative treatment for oral lichen planus when the patient is contraindicated for steroids or immunosuppressants.